So imagine you're in front of the professor and he asks you what is general anesthesia, and you tell him that it is a controlled reversible CNS depression. It's CNS depression which is controlled and it can be reversed, and that is general anesthesia. What are the goals in this particular anesthesia? What aspects do we have to check? So analgesia, the patient should not feel pain. Amnesia, the patient should not have the memory of where the cut was done, and loss of consciousness, then muscle relaxation should be done, and reflex suppression should be there. And we have to understand that not one single drug can do all these things: analgesia, amnesia, loss of consciousness, muscle relaxation, and the reflex suppression. And balanced anesthesia using multiple drugs is given. So you're in the OT, you're standing beside anesthesiologist, beside the table where patient is placed, where patient is positioned, and the drugs to be pushed of anesthesia we have to see. Before the surgery, a pre-anesthetic drug is given. It is for sedation and for anti-anxiety. The patient is already so anxious whenever he is positioned on the table, and for that we give him a pre-anesthetic, and sedative agent is given. Induction. Now entry, the patient should enter into unconsciousness slowly, and that's why IV drugs like thiopental, propofol are given, and the patient will sleep in around 25 seconds. For the maintenance, for this particular unconsciousness to sustain, inhalational drugs, IV drugs are given. Muscle relaxants are added for intubation, and recovery. For recovery, drugs are stopped and their drugs are stopped and the patient wakes up. Now we have to see what are the stages of anesthesia. Let's get back to the stages of anesthesia. Brain should shut down layer by layer. So in the stage 1, your analgesia should happen. You should not feel pain. The patient should not feel pain. Patient just got the drug and he's still conscious, but pain is reduced. His spinothalamic tract is blocked. Consciousness is present. Hearing increases. Okay, hearing increases in this case, and there is no amnesia. There is no yet loss of memory. Patient can still talk. Okay. In stage 2, there is excitement, delirium. In the first stage, we saw analgesia was there. The patient was not able to perceive the pain. Next, there will be excitement, delirium. The patient's brain cortex, it is suppressed, but lower centers, they are active, and that makes it chaos. So violent, combative, irregular BP, respiration, amnesia is present during excitement, delirium. And that is why we skip it. This is a dangerous stage. Irregular BP, respiration, violent, combative patient is there. And that's why we skip this phase using IV thiopental before inhalation. Next is the stage 3. It is surgical anesthesia, where the surgeon starts operating and there is regular respiration, muscle relaxation, and loss of reflexes are there. And this surgical anesthesia, stage 3, is divided into 4 planes. First plane is there is eyeball movements are present. Then the reflexes, they are intact. In phase 2, it is in the plane 2, it is important. The most surgeries happen. There is loss of corneal reflex, light reflex, laryngeal reflex, and the respiration is slow, but it is regular. In the plane 3, deep anesthesia is there. The pupils, they are dilated. No reflexes. Okay. First of all, in the plane 2 also there were no reflexes. In plane 3, there will be no reflexes, and there will be abdominal breathing. In the plane 4, there will be complete muscle paralysis and fully dilated pupils. In plane 3, the pupils had started to dilate, but in the plane 4, they will be fully dilated. So we understand that first of all there was an analgesia, loss of pain sensation. Then there was excitement, delirium, which was skipped by giving IV thiopental. And then there is surgical anesthesia, where there are 4 planes. And what in these 4 planes, what we do, there is we maintain regular respiration, we do muscle relaxation, and we slowly lose the reflexes. Okay. In the first plane, there will be eyeball movement, there will be reflexes. In plane 2, there will be most surgeries happening, and that's why plane 2 of the stage 3 is important. And here will be loss of all these reflexes. And in plane 3 also there will be no reflexes, but the difference would be that in plane 3 there will be deep anesthesia, abdominal breathing, and here in plane 2 respiration is there, but it is slow and regular. Then in plane 3 and plane 4, the difference is the pupils have started dilating in the plane 3, whereas in the plane 4 they are fully dilated. In the stage 4, there is medullary paralysis, and it is a dangerous case. You overdose the patient with the anesthetic drugs, and its respiratory center, the vasomotor center, is depressed, and there is death. Okay. And so let's revise again. There are 4 stages. First of all, analgesia. Second, excitement, delirium. Third, what? Surgical anesthesia. And fourth is the medullary paralysis. And in stage 3, the surgical anesthesia, there were 4 planes. In the first plane, what was happening? Reflexes were intact. Eyeball movement was there. In the plane 2, their surgeries were happening. Respiration was normal. Most important, loss of reflexes is there. In plane 3 also, loss of reflexes. But differences in plane 3, there will be deep anesthesia. Pupils will start dilating, which will be fully dilated in the plane 4. And in the plane 4, there will be complete muscle paralysis. And in the stage 4, where there is medullary paralysis, where in the medulla, your respiratory center, your vasomotor center will be depressed, and death can occur. When this occurs, whenever there is overdose of the drug. So clinical pulse, what is there? It is best indicator of surgical anesthesia. That is loss of corneal reflex and regular respiration. And the types of general anesthetics we have to see now. For this, I will have to bring up a beautiful. First of all, let's name them. So inhalational and intravenous, 2 types are there. In inhalational, the gas is nitrous oxide. Nitrous oxide, always remember, the rus is given to the patient so that the nitrous oxide, it will work as anesthetic. Next thing is liquids. Liquids like dish, desflurin, I for isoflurin, S for sevoflurin, and halothane. So DISH, dish, we have to understand. Then intravenously, fast inducers are there and slow inducers are there. Fast inducers are Barbies. What were they? Thiopental and hextal something was there, and propofol and etomidate. Okay, so thiopental and hexital, they were going on a date, and etomidate and propofol is also there. So they are the fast inducers. Slow inducers, they are the benzodiazepines and benzodiazepines, and they are like the monks and the diazepam and midazolam. And the special one is the ketamine, the magic person. He gives us dissociative anesthesia, something like a term is there for ketamine. I don't remember now. Now induction. What does induction? First of all, I will see the yes, this is the page we have to imprint inside our brains, and that is the general anesthetics, they are inhalational forms and inhalational and intravenous forms. Inhalational, most important there is nitrous oxide, and the others are DISH, desflurin, isoflurin, sevoflurin, and halothane, and others are methoxyflurin and enflurin. Okay, so and what we are doing, we are inducing them to the patient, so we are giving it to the patient, and so the patient will be able to go into analgesia, amnesia. Okay, now the intravenous, those are barbiturates, and this is a ketamine, this is a special drug, and these are all the fast inducers. There are fast inducers and there are slow inducers. Among fast inducers, there are these ninjas. They are giving milk of propofol for amnesia, milk of amnesia, that is propofol. And so one of them is propofol, another one is etomidate, and these two are hexital and pentyl. Let me see the drugs names in the book. So the drugs names are, barbiturates are thiopental and methohexital, and the non-barbiturate ninjas, they are propofol and etomidate. And the slow inducers, the monk, it is having 3 drugs, and those are those benzodiazepines, those are diazepam, lorazepam, and midazolam. And the ketamine, it is a dissociative anesthetic agent. Ketamine, it's a magic person is there. Okay, so Joker, this particular perfume shop, these Barbies, these non-Barbies ninjas, one wants to go with a date, and this will give the milk to the patient, propofol. This is ketamine, and this is benzodiazepines. Now let us go to, now that we have seen the types of general anesthetics, now let us understand what is the meaning of induction. It is time from the drug administration to the surgical anesthesia, till the patient reaches surgical anesthesia. So fast induction, the fast, that means less time between drug administration to surgical anesthesia. It will avoid the stage 2 danger. And what was the stage 2 danger? It was excitement, delirium, in which the patient was very combative and violent, and his brain cortex, it was suppressed, but his lower centers, they were active, and that's why the patient was chaotic. There was irregular BP, respiration, there was amnesia present. That means the patient wasn't having the memory of what he was doing. And yeah, so whenever there is fast induction, we skip this stage 2 excitement, delirium, combative thing. Okay, and the IV drugs are used first. And why brain affected first? Because there is high blood flow, so the lipophilic drugs, they cross the blood-brain barrier fast, and the brain is affected, but the lower centers, they are active. And for the fast induction, the IV drugs like thiopental, propofol, they are given. And additional drugs during induction, for fast inductions, the IV drugs are given slowly, they are injected slowly. Additional inhalational intravenous anesthetic like ketamine may be given to produce desired depth in the stage 3 plane 2 of surgical anesthesia. To produce the desired depth of surgical anesthesia, then skeletal muscle relaxants like pancuronium, atracurium, or succinylcholine are also co-administered to facilitate the intubation and muscle relaxation. Okay, so inducing agents, they are lipophilic and they cross the blood-brain barrier and affect the brain. We have seen that. Okay, now why anesthesia will end? There will be no metabolism of the drug, you have to understand, and the anesthesia will end due to redistribution of the drug from the brain to the muscle and to the fat, and that's why a single IV dose, it will have short action, and that's why we see anesthetics always giving injections after multiple times after some durations. And how is the maintenance is done? Now that we have seen what is induction, let's see what is maintenance of during anesthesia. So in maintenance, we have to keep the patient in the stage 3 plane 2. In stage 3, that means in the surgical anesthesia, in the deep anesthesia, we have to keep the patient, and we have to adjust the depth using inhalational agents. Okay, and we have to monitor the BP, heart rate, and respiration. And what is maintenance? We have seen. Vital signs are to be monitored. Okay, so what is the situation and what is its meaning? There will be movement, increased BP on incision, and that is during light anesthesia. Decreased BP, decreased respiration, it is during deep anesthesia. Cortex thinking will be gone. Limbic emotions, they will be chaotic in the stage 2. Brainstem reflexes, they will be suppressed in stage 3. The medullary parallel stage, medulla life will be gone. Okay, in overdose. During stage 3, this is happening now. Then why is stage 2 dangerous? How it is avoided? So why is stage 3 plane 2 ideal for surgery? Why does thiopental act within seconds? And what is the difference between induction and maintenance? And why does anesthesia terminate by redistribution and not metabolism? Depth of anesthesia depends on the partial pressure of the anesthetic in the brain. Okay, this will be seen in the maintenance thing, that whatever the anesthetic is there, it is in the brain. And what is its partial pressure? That will determine the depth of the anesthesia, and not the dose of the anesthetic will determine. So what is partial pressure? We had always seen that individual gas, what it exerts pressure on the wall, that is partial pressure. So individual drug, how much effect it provides, that gives us the depth of anesthesia. So whole game is about how fast the drug reaches the brain, how much pressure it is exerting towards the brain, and how much it is staying there. So flow of the drug, you have inspired there, it is in your alveoli, it goes to the blood and then to the brain. So movement, it depends on the partial pressure gradients. So key concept is of steady state. When the partial pressure in the alveoli, blood and the brain is equal, then anesthesia will be stable. So what is written in the book, that the rate of such transfer till the attainment of the steady state depends on alveolar wash-in, solubility characteristic of the anesthetic drug, its concentration in the inspired air, and the pulmonary ventilation rate, the cardiac output that controls the pulmonary blood flow, transferring the anesthetic gas from the alveoli to the blood flowing through lungs, and the partial pressure gradient of the anesthetic drug between the arterial and venous blood before its redistribution to all the tissues of the body. So all these together lead us the 6 factors. They determine the rate of transfer of the anesthetic from the alveoli to the blood and to the brain. So first of all, talking about alveolar wash-in, it is a process wherein the inspired anesthetic mixture, it replaces the normal air inside the lung. So our lung is there, inside our lung normal air is there, and that normal air should be replaced by inspired anesthetic mixture, and that is called as alveolar wash-in. So fresh anesthetic gas that enters the lungs and it will replace the air. So easily written here. So this will be faster if high ventilation is there, and it will be slow if large functional residual capacity is there, lungs are already full. So independent of the drug properties. Then solubility. So yeah, alveolar wash-in, how it will affect the rate of the transfer we have seen. Now let us see the rate of the transfer of the anesthetic. How will it be determined by solubility? It is a rank-making concept. What does that mean? No, this is your rank. So blood gas partition. Okay, these questions are asked, so that's why it is talking about rank, so it is important. Blood gas partition coefficient. So B for blood, G for gas, and P for is the partition coefficient. And what does that mean? That how much drug is dissolved in your blood? If there is high solubility, then the drug gets trapped in the blood, and there is low solubility, that means quickly builds pressure and goes to the brain fast. So we want low solubility so that the drug will go to the brain fast. So low PB by G is there, then there will be fast induction, then there will be fast stage 3 attainment. And high PB by G, then there will be slow induction. So order of these drugs, methoxyfluorine, it will give us what is there, yaar? So the blood gas wala jo partition coefficient hai na, it is the very highest in methoxyfluorine, and then there is halothane, N-fluorine, isofluorine, sevofluorine, desfluorine, and nitrous oxide. So fastest working, so lesser the PBG, fast will be the induction, fast will be the anesthesia, and so fastest working are nitrous oxide and desfluorine, and if there is high P by G, then there will be slow induction, there will be slow anesthesia, and those drugs are methoxyfluorine. So its real understanding is that blood should act like blood equivalent to sponge. Why? Because if big sponge is there, if high solubility in the blood is there, then it will absorb the drug and there will be slow brain, then there will be slow delivery of the drug to the brain. But if the small sponge is there, if there is low solubility, that means low solubility means low PB by G, low blood gas partition coefficient. Then what will happen? The drug will escape and it will reach brain fast. Next is about oil gas partition coefficient. So how much drug likes the oil? Oil means brain, the barrier. How much drug it likes the lipid. So if there is high lipid solubility, then there will be high potency and low MAC. What is MAC? It is minimum alveolar concentration. If the drug is going to the brain fast, then there will be minimum alveolar concentration. No? It will be low. So, and this is very important, whenever there is high oil gas partition coefficient, that means there is high lipid solubility, high potency, and yes, brain is lipid rich, so lipid loving drugs, they have stronger effect. What is MAC? We have seen lower MAC, that means more potent drug in anesthesia. Inspired concentration. How does the inspired concentration of the drug, it affects the transfer of the drug to brain. So doctor increases the percentage of anesthetic, higher the concentration, faster will be the induction. Halothane increased initially 3 to 4% and there will be induction, then reduced 1 to 2% and there will be maintenance. How does the pulmonary ventilation? It will affect, so more breathing, hyperventilation, faster induction, respiratory depression जरा असेल तर slower induction, cardiac output तुमचं जास्त असायला हवं, so more blood removes the drug from the alveoli and slow rise in the brain concentration. Wait. जर हाय कार्डियक आउटपुट असेल म्हणजे युजली आपला 5 लिटर असतो, म्हणजे किती तुमचं पंप करते पर मिनिट हेच ना, तर ते जर जास्त असेल तर तुमचं जे ब्लड आहे तर इट विल रिमूव्ह द ड्रग फ्रॉम द अल्व्हेओलाई फास्टर अँड देर विल बी स्लोअर राइज इन द ब्रेन कॉन्सन्ट्रेशन. अच्छा, and increased cardiac output, and in return, हे book मतलब वाचते हैं आम्ही. So increased cardiac output, and in return, pulmonary blood flow results in more effective removal of the anesthetic drug from the alveoli to the blood, and from the blood to the alveoli. Okay, speeding up the induction and recovery from anesthesia. ओके, तर म्हणजे लवकर तुमचा ब्लड फ्लो होत आहे फ्रॉम द अल्व्हेओलाई टू द ब्लड आणि फ्रॉम द ब्लड टू द अल्व्हेओलाई. त्यामुळे तुमचं ड्रग जे आहे ना ते लवकर काम पण करतं आणि ते रिकव्हरी पण लवकर करतं. ठीक आहे, आणि आपल्याला उशिरा रिकव्हरी पाहिजे, त्या लवकर नाही आहे. सो अँड जर लो कार्डियक आउटपुट असेल, ॲज इन द केस ऑफ कंजेस्टिव्ह हार्ट फेलियर और COPD, या केसेसमध्ये ना स्लोअर डिस्ट्रीब्युशन इश्यूज असतात, कारण तुमचं ब्लड लवकर म्हणजे कारण तुमचा हार्ट पंप करत नाही, कार्डियक आउटपुट कमी असतो, त्याच्यामुळे फास्टर इंडक्शन असतं. सो द ब्लड गेट्स इनफ टाइम टू गो टू युअर ब्रेन, रीच देअर अँड ठीक है. Then there is arteriovenous gradient. There is arterial blood, venous blood, and the blood goes to the tissues and it comes back. ठीक है. So if tissues absorb more drug, then venous blood has less drug and the gradient is increased. So there will be slower brain equilibration. स्लोअर ब्रेन इक्विलिब्रेशन म्हणजे अरे यार मला नाही कळलं आहे. अजून एकदा काय म्हणते बघ की the anesthetic concentration gradient between arterial venous blood depends mainly on uptake of anesthetic by tissue. After tissue uptake during arterial circulation, there may be a great difference in arterial venous anesthetic concentration gradient because venous blood returning to lungs may carry lesser anesthetic than arterial blood. The greater this difference in anesthetic partial pressure, the more it has been taken up by viscera, muscle, etc., and the more time it will take to achieve equilibrium within the brain. Acha. So there will be slow brain equilibration. That means the tissue is taking the drug and it will take more time to reach the it will take more time to reach your brain, and so there will be what thing happening. So what is the tissue behavior? Let us see. The tissues, the important organs like brain, heart, liver, what they will fast uptake is the effect on them, and in muscles there will be large storage and it will delay the transfer, and fat, it is a huge storage and it will slowly release the drug. So fat, it will delay the recovery. And let me read the text from the book again. So what it is saying, that organs like brain, heart, liver, kidney, which are highly perfused, they significantly influence the arterial venous anesthetic concentration gradient and rapidly attain a steady state with the partial pressures of the anesthetic in the arterial blood. म्हणजे तुमच्या आर्टेरियल ब्लडमध्ये जेवढं काही अनेस्थेटिक आहे त्याच्यासोबत ते लगेच स्टेडी स्टेट मेंटेन करतील. Inhaled anesthetic continues to be distributed in various tissues even during phase of maintenance, but that distribution in other tissues has little impact on the time of desired anesthesia. Skeletal muscles, अच्छा हे तर सांगितलं. As the venous blood depleted of anesthetic returns to the lungs, हे important आहे. More gas moves into the blood from the lungs according to partial pressure gradient. आपल्याला माहिती venous blood जे असतं लंग्सकडे जात असतं कारण की त्याला ऑक्सिजन रिच व्हायचं असतं. So more gas moves into the blood from the lungs according to partial pressure. म्हणजे lungs is basically alveoli. तर alveoli मधलं जे आणि इक्विलिब्रियम जेव्हा रीच होतं, there is no further anesthetic uptake from the lungs into the blood. अच्छा. समजलं. सो तुमचा एक असा फेज येतो, आर्टेरियल ब्लड जेव्हा आपल्या टिश्यूकडे जात होतं, टिश्यू ते ड्रग घेत होतं आणि ते विनसमधलं ते ड्रग कमी करत होतं आणि ते परत विनस ब्लड जे आहे ते लंग्सकडे जात होतं आणि लंग्समध्ये आपण ऑलरेडी इन्हेलेशनल ड्रग्स देतोय, परत ते इन्हेलेशनल ड्रग त्या ब्लडमध्ये जाणार, विनस ब्लडमध्ये, आणि एक असा हे सायकल रिपीट होणार अंटिल अनलेस आपलं जे आर्टेरियल ब्लडमधलं जे ड्रग आहे ते आणि विनस ब्लडमधलं जे ड्रग आहे ते दोन्ही इक्वल होणार, आणि तेव्हा काय होणार, तेव्हा दे हॅव कॉल्ड इट फर्दर अपटेक फ्रॉम द लंग्स जे आहे ह्याचं ड्रग्सचं ते होणार नाही. ठीक आहे. सो या टिश्यू बिहेवियर बघितलं आपण, ब्रेन, हार्ट, लिव्हर, किडनी यांच्यामध्ये फास्ट अपटेक होतं, मसल, फॅट. रिकवरी बद्दल बघायचं, एनेस्थीसिया संपतो, गॅस इज फ्लोइंग आउट, रिव्हर्स ऑफ इंडक्शन, इट अगेन डिपेंड्स ऑन द पार्शियल प्रेशर ग्रेडियंट्स अँड रिडिस्ट्रिब्युशन अँड नॉट मेटाबॉलिझम. व्हॉट इज डिफ्युजन हायपॉक्सिया? Nitrous oxide, it rapidly leaves the blood and enters the alveoli and it dilutes the oxygen in alveoli. So less oxygen, then there will be hypoxia. Okay. So why with nitrous oxide? It has very low solubility and it will leave the blood very fast and it will replace the oxygen. So that is diffusion hypoxia. So give 100% O2 during recovery to prevent this. So gas enters the lungs, dissolves in the blood. It depends on the blood gas partition coefficient. It will reach the brain. It will depend on the pressure, the partial pressure. Then it will cause anesthesia. It will redistribute to muscle fat and it will leave the body. There will be reverse flow. So why does low blood gas coefficient cause faster induction? So okay, what we had seen in blood gas coefficient, there will be faster induction because you will have low solubility in the blood and hence it will quickly build up the pressure and it will quickly go to brain. Next question is, why is high lipid solubility associated with high potency? Yeah, I know that. How does cardiac output affect anesthesia induction? Okay, why does nitrous oxide cause diffusion hypoxia and why is recovery mainly due to redistribution and not metabolism? Ouch. Low cardiac output, less anesthetic removed, alveolar pressure rises quickly and brain receives the drug faster. So initial recovery is due to redistribution and later the elimination is done by metabolism excretion. So the patient wakes up before the drug is metabolized. After your drug is stopped, the drug will move to particular the organs and so the brain concentration will be rapidly fallen. It will rapidly fall down. Okay. Yeah. Next thing we have to see that how your anesthetic will leave the body, what decides the recovery speed, and yeah. So anesthetic goes out mainly via lungs exhalation. So less blood soluble drug, it will leave fast. There will be fast recovery. More blood soluble like halothane, it will stay longer and it will give slow recovery. Nitrous oxide, it will come out fast. Halothane, it comes out slow. Liver metabolism, methoxyfluorine, 70% of it is highly metabolized in the liver and slow recovery in the liver disease, because liver it cannot metabolize it and it cannot reduce its concentration and it will lead to slow recovery. Nitrous oxide, almost no metabolism, pure washout will be there. So hepatic insufficiency, it will delay your recovery. Next thing, if you give halothane to a patient with liver disease, drug stays there long, the liver is not able to metabolize it and the patient doesn't wake properly. Okay? So what is potency and how it is related to minimum alveolar concentration? तुमच्या अल्व्हिओलायमध्ये कमीत कमी त्या ड्रगचं कॉन्सन्ट्रेशन. सो सर्जन कट्स द स्किन अँड विल पेशंट मूव्ह ऑर नॉट. ठीक आहे, हे बघायचं आपल्याला. सो व्हॉट इज मॅक वी नो, इट्स अ पर्सेंटेज ऑफ गॅस नीडेड टू प्रिव्हेंट मूव्हमेंट इन 50% पेशंट्स. ठीक आहे, पेशंटच्या मूव्हमेंट आहे की नाही हे इथे लिहायला हे वेडे लोक नाही. हे लिहून त्यांना तुम्हाला ही डेफिनेशन समजवायची आहे की किती ड्रगचं मिनिमम कॉन्सन्ट्रेशन पाहिजे अल्व्हिओलायमध्ये. पर्सेंटेज ऑफ गॅस नीडेड टू प्रिव्हेंट मूव्हमेंट इन 50% पेशंट. जर लो मॅक असेल म्हणजे तुम्हाला कमी कॉन्सन्ट्रेशन लागत असेल त्या पेशंटला शांत करायला, तर मग त्याची हाय पोटेन्सी आहे. आणि जर तुम्हाला खूप जास्त ड्रग द्यावा लागते त्या पेशंटला गप्प बस म्हणायला, तर मग त्या ड्रगची लो पोटेन्सी आहे. सो मिथॉक्सीफ्लोरिनची सगळ्यात कमी मॅक आहे आणि नायट्रस ऑक्साईडचा खूप जास्त मॅक आहे, म्हणजे त्याचं पर्सेंटेज खूप जास्त ड्रग हे नायट्रस ऑक्साईड द्यावं लागतं त्या पेशंटला गप्प बस म्हणायला. सो इवन 100% गॅस इज नॉट इनफ टू प्रिव्हेंट द मूव्हमेंट ऑफ द पेशंट. सो इट इज अ व्हेरी वीक एनेस्थेटिक अँड इट्स मॅक इज ग्रेटर दॅन 100%. So why it is a weak anesthetic? Its lipid solubility is more, its potency is more, but its MAC is very less. What are the factors that decrease the MAC, that is the minimum concentration of the drug in alveoli required to stop the movement of the patient? Age. तुमचं जास्त एज असेल तर ते मॅकला कमी करेल. जर मॅक कमी असेल तर ते पेशंट लवकर शांत होईल. हायपोथर्मिया आणि CNS डिप्रेसन्स लाईक बेन्झोडायझेपाइन ओपिओइड्स. ठीक आहे, तर वाढलेल्या वयामध्ये आपण त्यांना लवकर सिडेट करू शकतो, म्हणजे लवकर त्यांना त्यांची मूव्हमेंट थांबवू शकतो. मॅकची एकदा डेफिनेशन बुकमध्ये बघ की टू प्रिव्हेंट मूव्हमेंट इन 50% ऑफ पेशंट्स इन रिस्पॉन्स टू अ स्टँडर्ड सर्जिकल स्किन इन्सिजन. ठीक आहे. What is the mechanism of action of these anesthetics? We have to see. In your brain, normally glutamate is there. It will do its excitatory function. GABA, it will do its inhibitory function. And what anesthetic will do? It will increase the GABA. Drugs like propofol, barbiturate, inhaled agents, they will increase the chloride ion influx, and they will make your neurons less excitable. They will make them quiet. Wait. GABA, it won't be increased. It will be decreased. Okay. So GABA, what is written in the book that there will be GABA-mediated inhibition at GABA A receptor. Increase chloride ion. Yes. GABA is inhibitory only ना यार. ग्लूटामेट GABA GG से क्यों कंफ्यूज कर रही है तू? GABA बढ़ेगा तो तुम्हारा ये ठीक है, सही था. ठीक है. देन NMDA ब्लॉक करून काय करणार? कीटामाइन करतं. ठीक आहे. NMDA ब्लॉक करून तुमचा ग्लूटामेट ब्लॉक होणार आहे आणि एक्साइटेशन प्रिव्हेंट होणार आहे. निकोटिनिक ACH चे आहे ॲसिटाइलकोलिन, त्याला कमी करून सोडियम एंट्री कमी करून डिपोलरायझेशन कमी करून एक्साइटेशन कमी केलं. थॅलॅमसमध्ये सेन्सरी शटडाऊन केलं, म्हणजे तुमचे सेन्सर्स आहेत ना ब्रेनकडे जात नाही. लॉस ऑफ कॉन्शियसनेस. कॉर्टेक्समध्ये मोटर आउटपुट कमी होतं, सो नो मूवमेंट. नायट्रस ऑक्साईड काय करतं बघून घे. तर त्याची प्रॉपर्टीज आहेत की स्वीट स्मेलिंग आहे, नॉन इन्फ्लेमेबल आहे, यूज विथ O2 अँड अदर एजंट्स. तर गॅस वाया मास्क देतो आपण. नंतर याचे ॲडव्हान्टेजेस काय आहेत की त्याचं आता आपण इथून आहे ना आपण पर्टिक्युलर ड्रग्सबद्दल बोलायला सुरू केलं. ठीक आहे. सो आता आपण नायट्रस ऑक्साईड, हॅलोथेन, मिथॉक्सीफ्लोरिन, एनफ्लोरिन, आयसोफ्लोरिन, डेसफ्लोरिन, सिरोफ्लोरिन आणि काही सगळे बघायचे. नंतर इंट्राव्हिनस बघायचे. फास्ट इंड्युसर, शॉर्ट इंड्युसर. फास्ट इंड्युसरमध्ये बार्बिच्युरेट आणि नॉन बार्बिच्युरेट. स्लो इंड्युसरमध्ये बेन्झोडायझेपाइन आणि लास्टला कीटामिन डिसोसिएटिव्ह अनेस्थेटिक बघायचा आहे. मग शेवटी आपल्याला न्यूरोलेप्ट एनर्जेसिया आणि न्यूरोलेप्ट अनेस्थीजियामध्ये फरक बघायचा आहे. नंतर आपल्याला बॅलन्स्ड अनेस्थीजिया बघायचा आहे आणि शेवटी जे की प्री अनेस्थेटिक मेडिकेशन आहे ना ते मी बघितलेलं आहे एका व्हिडिओमध्ये. सो आपलं काम खूप कमी आहे, आपण पटकन आटपून घेऊया.